Professor H Maduro from Groningen, the Netherlands, giving us some futuristic new aspects about alternative ways to treat, to irradiate breast cancer with protons.
Thank you. I would like to thank the organizing committee for this opportunity and also for the hospitality here in this beautiful Vienna. I'd like to start sharing with you my views about what I think about this step. Should proton irradiation be the treatment of choice for local regional irradiation in breast patients? My answer is yes, but, and I hope that in the coming 20 minutes I can explain to you and bring over why my view is like this. Based on the presentation of my very much esteemed colleague and friend, Professor Poortmans on Wednesday, in which he warned you about protons, I would like to add to that it's not a matter of caution, but selection. And also that's a theme I want to address in my presentation. Going further, to understand why we want to use protons irradiation in breast cancer, we need to know something about the basic physics about the difference. As you see, photons are X-ray, which we all know through our Röntgen images, like this famous finger, which was one of the oldest applications of X-ray, and all other appliances which we do, is that radiation to X-rays slow down. So we're not able to stop them completely, but through passing through matter, it will slow down in its energy transfer. The other thing is that protons are particles with a given energy they stop at the depth we have actually programmed them to stop. And based on this difference between slowing down energy and stopping energy, we will benefit of using proton therapies for the distal part of a target. I will show you this in a comic representing the dose distribution, how the dose falls off in, for example, a patient. On the left side, we'll see, for example, here, you have the skin. Going through the deep, you'll have a tumor over there and ending with, in this case, a heart or any other organ at risk in particular. If we use photons, which we have learned in the previous slide, that slow down, we need a certain energy that will slow down, but go through this patient, fictive patient, and slow down even in the region behind the target, especially ending up in the regions we don't want to irradiate. If we use protons, as I've said, it's a certain energy given, and it gives a what we call a Bragg peak, ending at a certain depth, and we program. So if you see here, you'll say you're not targeting the target as you want. What we do is giving several proton Bragg peaks to form this spread out Bragg peak, and by that way, we avoid the dose after the target. In this case, all this area receive almost no dose, which is beneficial for all things that are behind the target. So, next question is, why do we want to apply this in breast cancer? One of the most important things is, and we all know that radiation is bad. Nobody wants radiation. And we give the fault to radiation of all toxicity, of a lot of toxicity happening in breast cancer patients. This is one of the slides showing you some of the cardiac toxicity, which we all know is part of the radiation treatment in breast cancer. This is a publication of the NKI in which they compare patients with radiation internal memory, no chain and without, and we see that in all three of those endpoints, heart failure, ischemic heart disease, and valvular heart disease, there is more toxicity when we irradiate the internal memory, no chain. And this risk is even larger when patients have cardiac risk factor, which is also seen in the publication of Sarah Darby in the New England paper. Other reason to want to avoid radiation is that we know that all kinds of radiation can cause other kinds of tumors. And those tumors, some of them are located in areas in we don't need to be, like the lung, esophageal, and contralateral breast, which is on the other side. For example, for sarcomas that we find in the breast, we don't think there will be an advantage of proton therapy because those tumors come in the regions of high dose area. So there's where you want to be, where you're dosed. So in that way, we don't expect any advances from radiation with protons. So as you see here, the relative risks are like 1.39 for lung cancer and 1.53 for esophageal cancer. And especially in young breast cancer patients, the risk of photon irradiation is 2.5 times higher when just irradiated with photons. So, having said that, this is a slice of an ordinary patient in which we see on the left side, which is this side, the target. In yellow, you see the breast, and this patient would have a medial located boost, which is this part. And for the small viewers, there is even the internal mammary chain, which is located at the level of the internal mammary arteries and veins. So in order to treat this, we, especially in photons, use this direction and that direction in order to avoid as much as possible of the body. But having said that, you'll always have an area which is located in the dorsal part of the rib cage, in which you'll have irradiation with photons which we don't want and we don't need. So the organs at risk we want to spare in this case are all located posteriorly to the target. Here we have the heart, the lungs, the esophagus, and the contralateral breast. So by using protons which stopped in the depth, we can directly imply a beam which is orthogonal to your target without adding extra toxicity or extra dose, because that's what we know, to the organs at risk mentioned in this case. So this is an example of what we call a dose distribution. The colors are in the several levels of the colors are illustrated here, representing the height of the dose, in which you see that in the upper panel is the proton irradiation, the lower panel the photon irradiation. That with photon irradiation, even the low dose, here we see 2 gray, disperse over great parts of the body in the several images like transversal, sagittal, and coronal. That large part of the heart and even the whole body get some radiation due to the photons appliances. And in the other cases, in the upper panel, when using protons therapy, we see that the dose to the rest of the body is limited to some uncertainties, but because protons are not the magic bull. If you irradiate with protons, you will have some dose somewhere, and you have some uncertainties. Thus, for example, in this area, you see that there is a little bit more dose in our organs that you don't want to have. Okay. What have we seen? We have seen in several publications, and all of them, what they show when you compare on paper in the computer the dose to the organs at risk between photons and protons, is that the dose to the heart, the LAD, if you consider that an important target, the left lung, the right lung, or the right breast, is lower with photons. In this case, what we see is that the heart dose was reduced from around 6 gray to around almost 0 with proton irradiation. And the same counts for the LAD. The left lung, the right lung gets 0, and the right breast is also, although it's low with photons, even lower with protons. Here I show you a publication of DASU in which they compared in 10 patients when they make a plan, and what you see here, the upper part is the white one, this one, is patients with free breathing and irradiation on the internal mammary node. The next one is free breathing, so patients are allowed to breathe freely, and irradiation of the internal mammary node. And the other two are with respiratory gating, which is explained by Professor Barteling, which is one of the techniques used, of mostly used, to reduce the dose to the heart. If we concentrate on the heart part, you see with the 4 different proton techniques, because that's what we're showing here, the dose to the heart, even though using free breathing, the dose is less than half gray in these 10 patients. So showing that by using protons, in which category of patients you want, the dose to the heart will remain low. To compare, I plotted here the data from Laurie Pierce, in which she reported more contemporary radiation doses, in which the red one is the median mean dose of 2 grays when internal mammary node chain is included. This also with photons dramatically improvements compared to older techniques, but yet representing the median, there will be patients with higher dose to the heart given conventional photon techniques. So what have we seen that those are summed up are some of the applications that the dose will be lower in the heart, the lung, the contralateral breast, and even in some of the more dorsally located shoulder musculature because of the gravities of the proton beam. Why not in breast cancer? So now I'm going to the part for my first slide in which I said, yes, but there are also reasons why not to do it. And one of the reasons is that the protons are less available. This is a publication in which they show the number of proton facilities in red and the number of patients treated with protons in the world. And the added data on the right-hand corner are the extra numbers extrapolated from other sites, in which by 2019 there are around 90 proton facilities in the world, compared to almost 8,000 photon facilities. So it is still a very scarce technique, which we know that has improved, and it was one of the advantages of having more facilities, is that also the technique of using protons have improved dramatically in the past years, giving us the opportunities to do things that we were not able to do in the past, like treating moving breast in breast cancer patients. Given a survey from Damien Weber done in 2050, from the 14 European proton centers, only 2 were treating breast cancer patients. And another very good reason not to use protons is that it's most costly financially due to the investment and exploitation cost of a proton facility, which in the Netherlands, for example, is a twofold of a photon treatment. Other reason not to use proton is that you can argue we don't have randomized control trials, but it will be very difficult to do a randomized control trial when you have non-equipoise between 2 treatment options. It would be hardly difficult to tell a patient that they will randomize to a treatment like protons in the lower part that's not giving any dose at all where we don't want it, like the heart, lung, and contralateral breast, and let them be randomized between a treatment that gives those doses to the areas and we don't want to do. Furthermore, we talked about breath hold, and others use, for example, proton irradiation to reduce the dose to the heart. Those techniques have never been put to the validation of randomized controlled trial. And none of us will question the use of one of those techniques nowadays. So I think it's especially the cost that's limiting us to use protons in breast cancer patients. But the most important reason not to use proton, in my opinion, is that with a modern advantage in treating breast cancer, not only technological advances, but also in selecting patients, we have been able to reduce the dose in many of those patients. We sometimes treat only the breast, we do the partial breast, we breath hold to reduce, we even do prone to reduce, and for example, the right-sided breast cancer don't have the heart in the treatment area. So I believe that most of our patients will not need protons to reduce the dose to the organs at risk. So which patients will need protons? That's the most important question. But I want to give one of the points I want to give you at this point is that we will not be using proton therapy to increase the breast cancer cure. The reason to use proton therapy is to reduce treatment-related toxicity and in that way improve the quality of the survivals and the quality of life of those survivals, representing healthy aging like in Groningen we propagate. So is there any literature at all? There is some literature. They're scarce, they're small groups, up to 50 patients, and a single center or a couple of centers participating. And what we see in those publications is that with older proton techniques, the skin toxicity is extremely high. Going to the more newer reports, we see that the skin toxicity have been reduced a little bit, but for example, post-mastectomy irradiation, the dose to the heart will be almost 100%, which with photons we are not able to achieve in any way, except for putting something on the chest wall to increase the dose. What we have now is that in partial breast, they have, or the paper report have an excellent control, low control with good cosmetic results, except in patients which have been fractionated twice daily, and that's also what we see with the publication shown by Dr. Boo, that twice daily will increase the worst cosmetic outcome. And what they say about whole breast and chest wall irradiation is that it is feasible and well tolerated, with all the caveats involved in small studies. There are some ongoing randomized control trials. The Americans are doing trials with cardiac toxicity as an endpoint, the REDCOM. They have trials comparing partial breast irradiation, and they're looking at the hypofractionation schemes. What I found interesting is a recently publication in 2009, so this year, in which from the National Cancer Database, which actually was reporting on which patient got proton therapy. But the interesting I would take out of here is that only 0.1% of the patients in the database got protons, and extremely high percentage got in stage 0 and 1, which in my opinion is not the right selection to use this costly technique. The median follow-up is about 5 years, and what they see is an equal overall survival, which will probably not be influenced by patients which not need proton therapy. And changing gears a little bit, I want to show you a little bit how we in the Netherlands have decided how we will select patients. The basis for this is the model-based selection approach, in which our health authorities have approved this as a valid tool to select patients to proton irradiation, even more to select any patient for more technological developments. One of the prerequisites of this system we have approved in the Netherlands that we need quality prospective data registration. So all patients that get protons based on this approach will have data, so we hopefully can show in the future that what we were expecting to have as reduction of risk will be real life. So in short, what they do is when you have a dose to an organ, you can report what the relation is between the dose and the side effect. If you can show that the dose can be reduced, you can calculate also what the toxicity will be with this new dose. And by having a difference, you will qualify for protons. How does it work? We need a dose effect relation probability curve, something that shows that giving dose to something will result in something bad. We need to be able to calculate for each individual patient what their or her or his risk will be, and at the end we'll need to show that when we reduce the dose with photons to the dose with protons, we'll have an absolute benefit of 2%. And the 2% is an arbitrary chosen value in the Netherlands, and we have been chosen to decide 2% that we think is high enough for for toxicity like heart toxicity that is very relevant for those patients. What have we found? The only model that applies for breast cancer is the model from Sarah Derby, in which we see that the risk of cardiac event will increase per mean gray dose to the heart, in which we see 7.4% adding per gray. We've been validated this in our own cohort in the Netherlands, and this is the basis of our model selection. So then we have on the national data of cardiac event, of what's the incidence of cardiac toxicity, we can calculate the individual base. This is based on the age of the patient, the present or the absence of a risk factor, and the mean heart dose. For example, we have a 40-year female patient with a cardiac risk factor. We do then a photon plan, like this, and then we see that the heart in the dose is 5, and according to this model, it will result in 4.3% absolute risk of a cardiac event, lifetime cardiac event in this person. What we then do, having surpassed this 2% threshold, we are allowed to make a planning comparison in which we make a proton plan and report a dose in it. For this example, is a fictive numbers, but the risks are the ones in our model. Is, for example, if this patient gets with protons 1 gray, which is very high for a proton technique, she will have a risk of 0.6%, and the difference is 3.7. So this patient qualifies for protons, and protons will be reimbursed. Next thing you have to do is talk to the patient if she wants the proton therapy. Which patients could qualify? We think some of the patients will be internal memory chain irradiation, the more extensive irradiation, young patients with long life expectancy, bilateral breast cancer, which complex techniques needs to be applied, special anatomies like pectus excavatum, and patients with cardiac risk factors. Having said that, I come to my conclusions, and I hope you can share them, is that dosimetrically, based on those, all breast cancer patients benefit from proton irradiation. This is the ALARA principle. We try to protect everybody against radiation. Why not also breast cancer patients? Not all breast cancer patients should get protons, and this is a cost-effectiveness issue. Not all patients need it, and it's more costly. And the third one is that some breast cancer patients will have a clinical benefit. The difficult thing is to select them, and you can do that based on life expectancy of the relative high dose to the organs at risk. Having said that, I want to thank the audience and also some of our collaborators, Anne Krijns with the cardiac program in Groningen, Hans Langendijk, the head of the department, Lisbeth Boersma and Caroline Verhoeven from the Master, which have done a lot of the proton work together with us for the Netherlands, and also the Dutch National Breast Proton Indication Committee. Thank you.